just waiting on Dr. Yee.
Oh, I'm here.
Oh, you're here. Oh, hi.
Good morning.
Good morning. How are you?
Good. How are you?
Good, good. Well, I'm going to go ahead and start things underway, if that's okay.
Sure.
Okay. All right. Wonderful. Even though people will be joining us, so I will be letting them in as they join us. So Dr. Christine Yee, she's a professor at the Department of Internal Medicine, Hematology Division at the University of Michigan and at the Rogel Cancer Center. Dr. Yee specializes in...
Molly,
Yeah.
Molly, I'm going to go get mine.
Molly,
Yep.
I can't see anybody but you.
Sid, that's
Yes,
your
I can only,
computer. That's your computer. You have to change your view.
I don't know how to do that.
Okay, well, that's what you're going to be then, unless Sharon can show you.
As I push the very place so I can see people or see you.
Okay, well,
No, I can't. Everybody's going. I just.
You have some little dots at the top of your picture of yourself in the top right where it says view.
Yeah, there are two options, speaker and the gallery. If you pick the option of gallery, you should be able to see the panel of audience and the speaker.
Where do I find gallery?
go.
In the top right, there should be a button that says view.
Yep.
Go to the view button.
I don't have.
Top right.
Top right. I got a dot.
Okay, go to the dots.
Go to the
Okay,
top.
that works. Okay. And then what?
Does it
Leave.
give you view options under the dots?
Participants.
Does it say gallery?
No, share content, participants, more, and then it goes away.
Oh,
content.
yeah. Your looks like your those are the bottom panels for us. Not sure why it's coming to your top panel right now. You know what?
This is a brand new.
It does say it does say his bandwidth is low.
Oh, I can see Dr. Yu now. That's fine.
Oh, okay.
It's coming in now.
Okay. Are you good, Sid?
I don't know, but I'm better.
Okay, we're gonna keep going.
Please do that.
Okay, very good. So Dr. Yee specializes in medical and multidisciplinary management of plasma cell disorders, including multiple myeloma. Her clinical and research interests have focused on developing innovative therapies and identifying novel biomarkers in myeloma management. Dr. Yee leads and co-leads the multi-institutional
That's not going to help you.
Okay.
National
Nope.
Oncology Cooperative Group.
They're in. I'm sorry.
SWOG myeloma trials. She also serves as vice chair for the SWOG myeloma committee and co-chair for the Big Ten Cancer Research Consortium myeloma committee. And that's actually my first question, if that's okay, Dr. Yee.
Sure.
My doctor, Dr. DeBach, who is from Henry Ford, mentioned to me that she sits on a committee with you that you run. And so I wondered if you could tell all of us a little bit more about that committee. And is this something our doctors should participate in, or?
Yeah, so probably your doctor was referring to the SWOG, Multiple Myeloma Committee. So NCI, National Cancer Institute, has three big cooperative groups conducting all the cancer clinical trials. And one of them is called the SWOG. There's historical reason why it's called a SWOG. We were thinking to change the name, but most of the institutional members from like all over the country, feels like SWOG is a name that has been used for years, for decades actually. So SWOG stands for Southwestern Oncology Group. And then there's another one called Alliance Group and another one called ECOG Group. So those three groups are the NCI cooperative groups for conducting cancer research, clinical research. So for each group, then we have disease groups. So for example, we have multiple myeloma, and we also have like leukemia, breast cancer, colon cancer, prostate cancer. So multiple myeloma committee is specializing in design national clinical trials for multiple myeloma and also Waldenstrom and amyloidosis. So that's probably the committee that your doctor was referring to. So it depends on each institution where they like kind of like a member institute. So University of Michigan and also Wayne State Carmanos are part of the SWOG. I'm not quite sure about MSU, but for a lot of like community hospitals like Henry Ford, like or the other like or Providence, St. John, I think like it really depends on their tradition, which group they belong to. So they can belong to SWOG, they can belong to ECOG or Alliance. But in terms of the efforts, actually NCI, National Cancer Institute, they coordinate all these, they coordinate the effort from these three cooperative groups so that we can conduct clinical trials not overlapping, but cover the spectrum of the disease so that we can have high quality and also practice changing results from these clinical trials. So traditionally, those big cooperative group trials focus more on phase 3. So I think like many of our patients are probably very familiar with this concept in terms of clinical trials because a lot of our patients participate in trials. So clinical trials, we have phase 1, 2, and 3. So usually phase 1 is more focusing on the novel drugs have never been tested. It could even be like a first in human type of clinical trial. Once they have like a more good results, good data, safety is an important aspect to look at for phase 1, early phase clinical trials. Then they will move into phase 2 and phase 3. So for a lot of clinical trials for our cooperative groups like NCI type of clinical trials, those are more phase 2 and phase 3, more late stage, meaning it's not like early phase for testing, more like a late phase will be practice changing type of clinical trials. So that's how you probably would see in clinic when your doctor is talking about different types of clinical trials. So in terms of participating, yeah, any kind of like community hospitals can be part of those efforts so that patients can participate in those trials.
All right, wonderful. Thank you for explaining that. I appreciate that.
Mm-hmm.
We do have some questions from George, Judy, and Neil. So if I think Neil just joined us. If he'd like to ask his question, that would be great. Oh, maybe not. Maybe we lost him. What about Judy?
So Dr. Yee, I have my question is in regards to my husband who had CAR T and did wonderful, and then the CAR T failed. He's high risk, and we are now at the point where his myeloma numbers have come back with a vengeance. And just wondering what University of Michigan is doing for patients like that.
Yeah, that is an excellent question. So if I can just step back a little bit talking about CAR T versus the others. So, so traditionally, early like 1900s, it was chemotherapy, and then later we have chemo-free like immunomodulatory agent, proteasome inhibitors. Those like a lot of patients are familiar with RVD, and also followed by transplant if patient is eligible. But transplant essentially is high dose chemotherapy, and then and more recently immunotherapy, and actually this is a field very exciting. And then so CAR T is one of them. And along in that category that we do have bispecific antibodies and also antibody drug conjugates, we call them ADCs. Now, when you look at those different types of immunotherapy, those more kind of like a focus on the modality, how the drug is delivered. The other thing that we actually have to look at is the target. So CAR T right now, we have 2 CAR Ts approved from FDA. One is from BMS, one is from Janssen more recently. Both of these 2 CAR T therapy, they are focusing on one target called BCMA. So when we look at those options, if the patient is already exposed to CAR T, BCMA targeted CAR T, the next option, usually we would look at bispecific antibodies. Those are both of these CAR T and bispecific antibodies are like a so-called T-cell directed therapy, which is to guide your T cells to get closer to myeloma cells. Hopefully those T cells can be activated from your body and then attack those myeloma cells. So for BiTEs, it has, from the name you can imagine, it has 2 arms. One arm is to connect with the myeloma cells. So it can be through that target, which is BCMA. And then the other arm is to connect with the T cells. A lot of times it could be CD3, CD19. It could be different receptors on those T cells. And then this antibody is trying to bring them together so that we hope that those T cells can attack those myeloma cells. By saying that, currently, 2 CAR Ts targeting BCMA, a lot of other BCMA targeted drugs are in development, including BiTEs, including ADC. Actually, ADC, antibody drug conjugate, this is the 3rd way of delivering those drugs, actually has been already approved by FDA, which is from GSK, belantamab. Now, the question actually, not just for patients, but also for doctors, are if you have the same target, the BCMA target on those myeloma cells, but you have different modalities to deliver this drug and then try to target this BCMA, how can we utilize those different modalities? Whether or not the patient already exposed to CAR T target BCMA, we can use BiTEs or we can use ADCs to do the same thing for the treatment. This is actually a question we don't know the answer yet. So if you look at some of the clinical trials, you can see some of the trials that they would say we would exclude a patient who already had any type of treatment, prior treatment targeting BCMA, if this is targeted to the BCMA. So this is something that it's a challenge that there are so many trials targeting the same thing, but whether or not the patient can be eligible for the next line of therapy. Eventually, we will have, so right now we don't have any BCMA targeted BiTEs approved yet. So I think like Janssen has one promising molecule that potentially can be approved early next year. So we are looking for the results from their trials. Now, by saying that, if those are all approved, targeting the same target, then how can we sequence those different treatment options? We will need a lot of data and to be combined with some correlative studies, meaning some of the translational research in the lab to tell us whether or not a patient can have another treatment for the same target. Now, by saying that, in addition to this BCMA target, we actually do have the other target in development as well. Sorry.
Oh, go ahead.
Okay.
Yeah.
To mute yourself.
Okay. All right. Sorry.
That's all right. So there's another target, for example, it's called the GPRC5D. And that is a molecule, a target that we can also use for myeloma treatment. And Janssen actually has one molecule and being developed, and we actually have that clinical trial in our University of Michigan. Now, there is another FH5. That's another like a target being developed by another company. So, as of for now, if you're looking for any clinical trials post CAR T, then I would say clinical trials would be the best bet. Now, however, there are a few other agents approved by FDA for relapsed patient in that clinical setting that your doctor probably can still consider. I don't know all the prior lines of therapy that your husband already received in the past. So it really depends on which regimen, which agent he already received, and then we can see whether or not there are other options for him. So I think that would be a discussion that your doctor will have to review like the prior history and then help you to make a decision.
Right, very thorough. So Dr. Yi, George has a question for you. It's in the chat box.
Okay, let me just take a look at the chat
I
box.
can read it.
Sure, so that the other
Ready? Yep. When is it best time to stop maintenance chemotherapy over 2 years or 5 years or 10 years or longer? Do you have algorithms to make this decision?
Yeah, George, you're asking a very good question. Actually, this is the question that we've been constantly debating in the past and then trying to get results. To the short answer is we don't know yet, but in the routine clinical practice, for example, in the clinic, if myeloma doctors are sitting in front of a patient like you, and we have to make the decision how long we should do the maintenance therapy, one important aspect that we look at is whether or not it's high risk or not. Like Judy just mentioned, like high risk patients. So high risk patients tend to have the biology of this disease, tend to have disease relapse a little bit earlier compared with the other patients. So traditionally, if your doctor review all the medical records with you, one test result is called FISH result. It stands for fluorescent in situ hybridization. Now, this FISH result actually can give you the information of the genetic component of the chromosomes from your myeloma cells. So don't confuse it with genetic diseases. It's not from one like a generation to the next. It's a different concept. It is more related to the cancer chromosomes. So traditionally, we consider, for example, deletion 70p, meaning deletion of chromosome short arm. P stands for petite, which is from French. It's a short arm. And also we have a 414 translocation, meaning chromosome 4 and chromosome 14, part of them, they have translocated, like a change in position. And then we also have 1416, 1420, and we also have, more recently, we actually have amplification of 1q. So Q actually is the long arm of chromosome 1, has like a duplicated copies for that chromosome. So those are a couple of like so-called high-risk features that we usually would see from the FISH testing. Now, if the patient has that high-risk feature, especially 2 or more, that is an indication for us to consider longer term for post-transplant maintenance therapy, for example, because of the concern that the patient may relapse sooner compared with the other patients. Now, if you are standard risk patients, we are not quite sure yet. We have several studies actually from CLGB that they did, oh, sorry, not CLGB, it's from the transplant CIBMTR. Actually, it's led by Dr. Philip McCarthy from Roswell Cancer Institute. So he led that study, conducted the post-transplant maintenance therapy, Revlimid, for 2 years, for example. Now in Europe, actually, especially I think it's led by the French group, they did a trial, actually only did 1 year maintenance therapy after the transplant. So you can tell, doctors actually at the time of the designing those clinical trials, we did not know whether or not 1 year is better, 2 years are better, or even 5 years are better. We don't know yet. So currently there are actually 2 clinical trials ongoing right now. One already opened, it's called a dramatic trial. It's S1803. So this is a trial from SWOG, from our myeloma committee. It's also called a dramatic trial. So it will randomize the patients into 2 arms after the transplant, and they will have Revlimid only versus Revlimid plus daratumumab. So daratumumab is, so FDA currently only approved Revlimid for post-transplant patients as maintenance therapy. Now this trial, we want to answer 2 questions actually. Number one, whether or not Revlimid plus daratumumab, which is an anti-CD38 monoclonal antibody drug, whether or not the combination is better than Revlimid only. And the second question this study is trying to address is, after 1 year of or 2 years of maintenance therapy, we will do a testing called MRD, minimal residual disease. If the patient is able to achieve MRD negativity, whether or not they should still continue versus they can stop. So this trial is designed to answer those 2 questions. And this one actually is enrolling very well, and actually the enrollment is ahead of the time for the target. And hopefully by the end of this year or early next year, we can finish enrollment, but the data will not be available immediately because, maintenance therapy, if you look at the disease progression or the death, it will take very long for us to see the event, which is totally fine for our doctors because we feel this is good for the patient. Because whenever, if some of the patients, they are very savvy, they even go to our annual meetings to attend those meetings and look at the data. And you can see a lot of curves, right? When you see those curves and a lot of tick marks on those curves, we call them events, meaning the patient progressed or patient died. So we actually want to see those events happening later and later, which is good for our patients. That means our patients are doing well. But the data from this a study, it will take quite long for us to have the data for the reporting. Now, this is one trial that for this patient population. There's another clinical trial is ongoing. It's called EAA181. So this is from ECOG Cooperative Group, led by Dr. Sajid Kumar from Mayo Clinic. I'm actually the SWOG champion. So once we have one trial, then we have the champion from the other 2 cooperative groups. So this trial is also called Optimum trial. So this trial is trying to see if the patient is able to achieve MRD negativity, whether or not they can benefit from either Revlimid versus Revlimid plus another drug called Ninlaro, which is also known as Ixazomib. That is the oral form of Velcade that many of you are familiar with. So this trial just opened a couple of months ago, and it will take, and the target actually is 1,000 patients. So it will take very long for us to have the data from that. So, so I mentioned the short answer to your question is we don't know yet, but I give you a longer version of the answer because we are still, this is an important question for us, and then we are still accumulating the data. Hopefully will give us more information. Now, a lot of patients would ask about MRD utility. outside of those clinical trial setting, I know some of our doctors would order MRD. Actually, in our clinic, we order MRD. So let me just explain to you when I order it outside of the clinical trials. So if I have a patient post-transplant, finished 2 years, standard risk, I don't know whether or not this patient needs longer or we can stop. Sometimes patient felt, if I'm doing well, no disease relapse, I'm tolerating the drug very well, I'm willing to continue, and my insurance can pay for it. And then we would say, yes, let's continue. That's certainly makes sense. But if there is a patient saying, I don't tolerate this well, it drop my blood counts and put me at high risk of infection. My insurance cannot cover that. And there's a lot of high copays for oral drugs. There are different reasons that the patients, they actually cannot continue the drug. And then I would recommend, how about let's get MRD testing? So I actually have routinely testing patients for this type of situations, but I do warn my patients because FDA approved this testing. And but FDA did not tell us if it's positive, what you should do. If it's negative, what you should do. So, and also, if you look at our guidelines from IMWG criteria, we actually focus more on sustained MRD negativity, not just one time. So a lot of patients say, Dr. Yi, my MRD is negative. Can I just come off the treatment? And I said, well, this is not a time that you can make immediate decision because you need actually 2 or 3, even longer years for the testing so that you know whether or not you are in sustained MRD negativity. So for patient scenarios that I just mentioned, if they have like 2 or 3 negative MRD testings, and then if they cannot continue, I say, well, if that is the case, it's reasonable for you to consider hold the treatment if you cannot afford it. I don't want you to use all your retirement fund to pay for these copays. It could be very costly. And then see, and also at the same time, we will actually monitor your myeloma labs just like when you are still on the treatment. And if there's an indication that the disease is coming back, then we can act upon that. So that's why there are a lot of discussions. There's no it's not like one answer can fit all, right? We have to discuss different factors. But for high risk patients, this is still challenging, and we tend not to discontinue the maintenance at this moment.
Okay, thank you, Dr. Yi. From George, he's wondering, is it possible to have liquid biopsies from regular blood or serum to find myeloma markers such as NGS or NGF without invading bone marrow biopsies by using mass spectrum?
I feel like our group of patients actually really having a lot of knowledge of multiple myeloma and are asking excellent questions. So actually this question is even for our myeloma research, we've been discussing that, and also when we design our clinical trials, we try to build that into our clinical trial design. So right now, actually, I'm co-chairing a SWOG-3, a phase 3 SWOG clinical trial for frontline therapy for frail patients, RVD light versus DARA-RD. So for this particular trial, actually, we are trying to build that into the correlative study and to see what is the best way to do. Now, in reality, doctors want to do a lot of things, but a lot of prohibitive factors. So, and finance is one of them. So that's why we cannot do everything we want. So this was discussed at our committee, how to monitor MRD. We have this discussion constantly, but one important progress from last ASH is this mass spec using peripheral blood to measure the MRD. Now, you need to think about MRD to have some kind of like a basic idea about this. So multiple myeloma is a disease with a clonal expansion of the plasma cells, right? So those not the normal plasma cell, but myeloma plasma cells. Those cells, actually, usually they live in bone marrow. That's why we need the samples from the bone marrow. Those cells, they secrete a lot of proteins. So we measure those proteins in the blood. So MRD right now, we are measure those absolute numbers from the bone marrow, measuring those number of the plasma cells. So we have flow MRD, we have NGS MRD. And you are absolutely right. We have to get the marrow samples for that. More specifically, it's bone marrow aspirate. Now, when you talk about mass spec, that is to measure the protein levels in the blood. So those are two different types of testings, and we don't have an answer which one is better yet. So that's why there are a lot of studies doing like a correlatives, like trying to do both at the same time and try to see whether or not they can be complementary versus one is better than the other. We don't know yet, so we need more research. It is promising, and this is the direction that we're looking at. We constantly look for biomarkers that can inform us of the disease response, whether or not we don't have to do the bone marrow biopsy to get that information. So this is the direction to go, but it's still too early for us to tell. But I think it's encouraging to see the data. So and the other thing is MRD certainly it's one type of response evaluation. So whenever we do blood work every month, when we evaluate your response, those are the blood work that we use for measurement of we call paraprotein. Those are the bad protein levels. And usually there are like 3 different types of testings we do. So your doctors do that every month or every cycle when you are on the treatment. But the MRD detection is the deepest response that we can measure for now. And there are different ways that we just alluded to. I don't have the absolute answer to that question, but what I can say is we have more basic research going on in the lab, and hopefully that can be applied to clinical practice in the future.
That would be great. I don't think any of us like the bone marrow biopsies.
Right.
Fun. They're not fun.
That's right.
So George had one more question, but I think because of time, I'd like to move on to Hale. And Hale Anderson's question, if we have time at the end, we'll go back to George, his third question. So Hale is asking, are there any myeloma trials using CRISPR technology, CRISPR? That's his first question. And Hale's second question is, why don't the drugs I am taking for myeloma protect me from other cancers like melanoma or prostate cancer? And I've actually wondered that myself because I was told by my doctor that I had a couple of basal cell carcinoma spots removed from my back. And she said that could be directly linked to the myeloma because I'm immunocompromised. I've been on immunosuppressants. So that's a good question.
Okay. All right. Thank you for those good questions. So number one, CRISPR, in the short format, we don't have CRISPR technology involved clinical trials yet in multiple myeloma. I know it has been used in the other types of diseases, but I would imagine because this technology is quite popular right now. So I won't be surprised if I see any of the trials designed in the future, but we certainly have to be very, very careful with CRISPR technology utilizing in disease modification because it's not just like as simple as you think, like I can replace one region. The genome actually, it's not just like the coding, very simple coding, because it's actually, there's topology. like we call that like those chromosomes, they actually have like 3D or even 4D structure. And then some of the changes at one place actually can change like the topology of the genome. So it's not as straightforward as we would imagine from the simple version of CRISPR technology. Number two is secondary malignancy in myeloma patients. So a couple of things to mention here. Number one, regardless of what type of cancer patients may have, it could be myeloma, it could be CLL, it could be the other types of cancer. When patients have one type of cancer diagnosis, we usually would consider the genome instability. Genomes are not stable. And this is something that has been in lab research for a long time. There are different ways to try to see whether or not we can use a biomarker to measure the genomic instability, for example. However, so far, we don't have any particular biomarker to say that the patient has unstable genome. Now, sometimes I have patients coming saying, when we review the family history, they would tell us like, I have this relative, that relative, different types of cancer. Sometimes if you look at some of the medical literatures, they would say it could be some of the unknown reason that the genome is not stable in this family that might put patient or their family members at high risk of developing different types of cancers. So that is like one aspect to look at that. Another aspect to look at multiple myeloma patients, there is one study the study that I just mentioned earlier is post-transplant maintenance therapy led by Dr. McCarthy. So in their paper published for this patient population, actually, the secondary malignancy incidence increased compared with patients not on this maintenance therapy after the transplant. So the authors concluded, and also this is a well accepted in myeloma community, is post-transplant maintenance with Revlimid can increase the incidence of secondary malignancy. So that's why whenever you are after the transplant, when you are in doctor's office to discuss the post-transplant management, we often would introduce Revlimid for maintenance therapy, but at the same time, we do tell patients that there is a risk of secondary malignancy. Now, there are also like different research to try to address whether or not is this this increased secondary malignancy is related to transplant itself versus related to the Revlimid long-term use, right? There are still a lot of like active research to try to address that question. And we don't know yet, but this is something that what we recommend is cancer screening, other types of cancer screening, like colon cancer, lung cancer, depending on your smoking history, breast cancer, cervical cancer, and skin cancer. So different types of cancer screening. Now, it doesn't mean that you have to have increased frequency for those cancer screening. You still follow those guidelines like your primary care doctor would follow for all those different types of cancer screening. But if you can stay on top of it, that would be very helpful and for early detection. So that's the current recommendations. Molly, you're muted.
There we go. Thanks, Dr. Yee.
Yeah.
So George's third question was, my partner carried plasmacytoma on the pancreas with 2 stents on her bile duct and pelvis after VRD and acupuncture and oriental medicine for a year, VRD light a year, and Velcade maintenance chemotherapy over 5 years from February 2011, and collected stem cells without BMT. She wants to know, she is cured under your algorithms. Is it possible to have BMT or CAR T immunotherapy or BiTE-specific immunotherapy or others by using these stored stem cells over 2 years or 5 years, 10 years or longer.
Yeah, I can tell George is very savvy with myeloma knowledge. Yeah, so this is a great question. So first of all, actually, congratulations to this patient because plasmacytoma in those, like I would assume like those are biopsy proven plasmacytoma. We actually call them extramedullary disease, meaning the myeloma usually they live in bone marrow. And then when they happen in at other places, in different organs, like pancreas, actually, it's very, very rare for us to see, even for plasmacytomas. So traditionally, extramedullary disease actually is very hard to control. And so I'm actually surprised, but I'm pleased to see that surprise actually, that this patient actually benefited from RVD light, which is a lighter version of RVD for frontline therapy and also without transplant. And so because for this type of patient, usually we would be very nervous to use very light version, and also and I would imagine probably it was because of the other comorbidities, your doctors probably picked that regimen, and also without a transplant. But by saying that, I'm so happy to hear that the patient is 9 years like after like a treatment and in disease-free, I imagine like in remission, right? Because usually you have to use imaging to see whether or not the patient still has the disease. So actually, this is type of patient actually we are very interested in knowing. So hopefully, so I know like this is 9 years ago. So that's why a lot of times we actually try to get samples from those patients to do the biopsy and keep some of the samples. Hopefully, we can learn from those lab research and to tell us why this patient outcome is so good. We would say those are like super responders, right? So to answer the question from George, whether or not the patient right now needs treatment, my answer is because right now the disease already declared itself, 9 years in remission, then there's no reason for you to initiate a new type of treatment right now. So I would not, even though you do have the stem cell collected, I don't think right now you need to consider that, even though we have immunotherapies right now, very exciting. You don't need it because you will not be eligible for it, which is good for you because those immunotherapies it's either approved or enroll patients for relapsed or refractory patients. And your case is not in that category. So you don't need those treatments right now. However, you have a lot of options if disease relapsed. Now, if you are asking me whether or not it's cured or not, if you look at our textbooks for multiple myeloma, it's still not curable as of for now. In clinic, we do see many patients actually live 10 years or even longer for disease-free. And we can argue maybe those patients, they have already cured. Occasionally, we do see patients who can relapse after a long time in remission. So that's why, again, to stress the importance that how we can have effective biomarkers to tell us who can enjoy long-term remission, who may need a treatment, because some patients may have early relapse. And the case that George just described is long-term remission for 9 years already. So so that's why a lot of times we actually ask a patient when you go for the procedure, can we get additional samples so that we can learn from it, we can do some research. So this is where science would help us more, hopefully.
Thank you, Dr. Yee. Neil, would you like to ask your question?
Yes, sure. Thank you for joining us, Dr. Yee, and good to see everybody. My question was, I had a stem cell transplant almost 3 years ago. Went through CyBOR-D before the stem cell transplant. Had a successful stem cell transplant at the Cleveland Clinic. I was on Revlimid for 2 years. Went okay, but then I started to rise again. I've recently transitioned in December of last year to Carmanos, working with Dr. Zonder. And he started me on Revlimid with DARA sub-Q, with the pre-meds, with the Benadryl and such. And I'm actually dual diagnosed with both AL amyloidosis and multiple myeloma. I was wondering what your suggestion was for maintenance treatment, because right now it's going quite well with the DARA Revlimid combination.
So thank you, Neil, for this question. Yeah, and you brought up the AL amyloidosis at the end. Initially, I was following your case and thought it was a multiple myeloma. Certainly, AL amyloidosis is a different disease. It's a sister disease of multiple myeloma. So there are different types of amyloidosis, and I would imagine your disease is called AL amyloidosis because there are different subtypes.
Yes.
Okay. So AL amyloidosis, some of the patients, so a typical AL amyloidosis, actually, they have actually low level of the paraprotein, like usually it's a free light chain, like more specifically lambda free light chain.
Yes.
And then and the patients may have, so AL amyloidosis for a lot of like myeloma patients, probably you're not familiar with this because even though this is a protein disease as well, but it has like the fibrils, like a type of protein that they like kind of like folded, misfolded, and then they can deposit onto different organs. So for myeloma, the usual organ involvement is like in the bone, in the kidney, but for AL amyloidosis, those amyloid protein, they actually can deposit into the tissues like heart, like kidney, like a liver, like a GI or nerve system.
Yes.
So disease presentation is different. Now, I won't go over like the entire disease, like there are a lot of things to talk about from amyloidosis, but to address your question, because you have both multiple myeloma and AL amyloidosis, I would imagine your paraprotein level probably is not very low, probably is on the higher side. So that's why you have this diagnosis of combination, because usually if you just have low level of the paraprotein, we just call this AL amyloidosis. Now, when you have the CyBOR-D at the very beginning, this is standard of care for AL amyloidosis, like until last year, because there is one drug, like one regimen approved for frontline therapy for AL amyloidosis, which is daratumumab in combination with CyBOR-D. Now, because you had a CyBOR-D before that approval, that was very appropriate for you to have that frontline therapy followed by transplant. And then now, if you have those numbers are coming up, adding DARA makes perfect sense. So and also not to mention that Dr. Zonder actually is the amyloidosis expert.
He's a wonderful doctor, wonderful.
Yes, that's right. So that's why I totally agree with the current management, and hopefully you can have like long-term disease control from that addition of the DARA.
Yeah, I was getting, like I say, my light chains were starting to rise and my protein, and the Nilara wasn't taking care of that. That's why I got the second opinion and actually transferred my care to Dr. Zonder. It was interesting, when I was originally diagnosed back in 2018, I was actually first diagnosed with the AL amyloidosis because exactly like you mentioned, the fibrils were attaching to my heart and it felt like I was having a heart attack. It was very severe, but they caught it in stage 1, which was wonderful. And once they did the bone marrow biopsies, when they also found the multiple myeloma dual diagnosis. And they were actually, before they found the multiple myeloma, preparing to put me on a clinical trial of the CyBOR-D with the DARA when the DARA first came out. But once they found the multiple myeloma, it knocked me out of the clinical trial because they wanted just people that were just AL amyloidosis specific. So it was interesting as far as everything that went through, and after all this time, what goes around comes around, thank goodness. And what Dr. Zonder was projecting based on my diagnosis was use the Revlimid for the multiple myeloma and then add the DARA to combat the AL amyloidosis, and my numbers dramatically improved within a very short period of time. I've been on it. I just started my 8th cycle of both Revlimid and DARA, and my numbers look excellent.
That's great. I'm so happy to hear that. So hopefully you will have a long-term remission from this good regimen. DARA is quite promising for both myeloma and AL amyloidosis. So definitely it can help both diseases.
And the sub-Q is so much easier and easier to deal with than the infusion.
Yeah, that's right.
Thank you, Dr. Yee.
Oh, you're very welcome. Molly, I saw more questions in the chat box. So let me see where we were. CRISPR, we already talked about CRISPR, plasmacytoma, we already talked about that.
Yeah.
Oh yeah, melanoma, prostate cancer, I think, yeah. Yeah, so myeloma treatment won't protect you from other cancers. It won't work like that. Mary, that's some difference between Molly's voice and Dr. Yu's is significant. Oh, that's the audio system Mary mentioned. Okay, it's not a myeloma question.
Yeah. So any other questions? Well, I actually have a question, Dr. Yee.
Sure.
So, for those of us that are multiple myeloma patients, what would you like us to walk away from this session knowing? Like, what do you think is really important in the myeloma world right now that you would really want your patients to know?
Yeah, so can I have a little survey? How many of you are newly diagnosed, like getting induction therapy, and how many of you are like having relapse disease, getting treatment for that purpose? Maybe I can give you a takeaway message based on like most of the the audience.
I relapsed after 9.5 years after my stem cell. And I had a CAR T study with Dr. McCarthy last year, and then a spot showed on my femur 14 months later. So right now we just did radiation and my numbers are not coming down, but they're not going up. So I just completed the radiation a couple of weeks ago.
Okay, so that's the relapsed case.
Mhm.
How about the others? Maybe I can say, how about relapsed? Can you just raise your hand so that I can do a quick count? So another relapse. Okay, 2 relapse. Oh, 3, 4. Okay, all right. How about the newly diagnosed? Or some of them maybe are like a family members, so you don't have to raise. Any like a newly diagnosed getting induction therapy right now? I don't see anybody. Okay, all right. So let's talk about the relapsed refractory disease. So I know like it is very frustrating a lot of times for our patients for relapsed disease. In the myeloma, sometimes we do see the pattern that you have the initial disease. A lot of times, like I like to draw like on a piece of paper for my patients, like to explain all these things. But hopefully you can see like my hands, how it's moving. So when you have the disease, like at the initial diagnosis, we measure your protein level or disease burden. And then you start from here. We give you some of the treatment, and then the protein levels are coming down. So every month we're measuring that. And then if you make a curve, make a graph, and then you can see the curve is coming down, which is very nice for us to see that your disease is responding to the treatment and the numbers are coming down. And then we have different levels of response based on these numbers. Now, inevitably, a lot of patients may have disease relapse, meaning like the numbers can go up, or you may have like a new organ involvement, like for example, in the bone or the other like plasmacytoma as the disease recurrence. So I totally agree with Laura's physicians approach for local relapse. A lot of times, if they are causing any troubles, we would consider radiation as local treatment. In terms of the systemic treatment, I mentioned earlier that we have immunotherapies coming up. So I feel we have more and more exciting drugs. I actually early this year, one fellow worked with me for a review paper talking about the relapsed refractory multiple myeloma patients. If you want to look for it, it's published in a Journal of Hematology Oncology as a review paper. And we have graphs, we have tables. I'm not asking you to know all these, just want to give you the idea. The graphs is showing that there are different targets. I mentioned earlier, the most commonly targeted right now is BCMA, but there are different targets in the research and in clinical trials. And then for each target, there are so many different, either treatment modality or different companies developing those. So it's good for our patients because we can look for different options. So I feel like we still want to aim for chemo-free, even though occasionally we still use chemotherapy, but we hope that we can have those chemo-free immunotherapy more and more promising, and also hopefully we can have those treatments longer remission. You can see a lot of data published that even for CAR T, a year ago when we talk about CAR T, it's such a new immunotherapy, but now you can see patients are coming to look for trials after CAR T. What does that mean? That means CAR T only offers maybe 1 year or 1.5 years or 2 years of disease free period, right? So our job as myeloma doctors, we want to look for how we can make that disease-free period longer. How to identify those patients who may stay in that remission longer versus who may have disease relapse earlier. So we are trying to correlate a lot of blood samples or bone marrow samples that from patients and correlate with their clinical outcomes. So so what I would say takeaway message is it's encouraging to have a lot of treatment options, but still it's challenging, and I feel like our group of patients are very savvy, having a lot of myeloma knowledges and knowing to go to those cancer centers that are offering clinical trials. That is really the best best management approach from your end, because myeloma is such a rare disease. It's not a disease that community doctors, they see breast cancer, prostate cancer on a weekly basis, but myeloma maybe every 3 months or every year. So myeloma is a rare disease and you need expert to help you.
I agree with that. That is for sure.
Dr. Yee, could I ask a question?
Sure.
Of course.
Go ahead and ask.
Okay. Lambda free light chains with my husband's multiple myeloma are starting to rise again. He is actually supposedly less than maintenance on ELO and Dex and Pomalyst. That is the only thing that has really kept his numbers under control for I think about 2 years in December. Previously, the Ninlaro, the Velcade, and he started only with Dex and Rev alone. Do you ever just raise what he's on, or does he need to go to a new therapy in general? Are those two options available?
When you say two options, are you referring to the combination of ELO Rev Dex versus just Rev Dex?
No, now it's ELO, Dex, and Pomalyst.
Oh, ELO
orally, the
Pom Dex.
Yeah, and that's what's doing a good job.
Mhm.
Would they were just telling me they're lower. Would they ever just raise those again, then because of his neuropathy, they kept lowering doses. And when I asked last month, they said the nurse practitioner said it was a little, I think, below what would be maintenance, because I was asking about maintenance, which they were going to look at. But with him, he's 83, and he other things didn't last very long that they tried. And I know Dara is a good new thing, but um, I don't know, is there a choice of just upping what's working well, or would you automatically go to something new?
So
He just had a 24-hour
uh,
urine sample and a thing, but they haven't done the next step, probably if they're up this month, would be a bone marrow to see exactly what's going on.
Okay, so I would imagine that the Elopalm Dex regimen, it's already a regimen that your doctor is using as relapsed disease. So because this is not a routine like maintenance regimen. So I would like from your case description, it looks like it's maintenance therapy with RAV and then disease relapse, and your doctor is doing Elopalm Dex. I understand that sometimes there's tolerance issues, and you were wondering whether or not he has to continue the Elopalm Dex forever versus like some of the drugs can be lifted. The answer is it really depends on how long he will be in remission with this regimen, and that can be considered, but with caution. A lot of times with disease progression, those regimens that we use actually is long-term until disease progression. However, I do have patients in my clinic with the early relapse, and we use the second line of therapy, and then they can achieve like over a year or even 2 years of disease-free. And then at that point, if they feel like they don't want to take too many medications because of different reasons, side effect is an important factor to consider. Then we sometimes would back off and then either adjust the dosing schedule or reduce the dose to make it a lighter or easier treatment for the patient. So that can be considered, but with caution.
Okay, that's what they've been doing. So it's down now, but his numbers are starting. They don't know why his numbers are starting to go up again. His lambda and his actually his the two together too. I can't think of the word, but you know what I mean. The lambda and the thing
Kappa.
together. But anyway, so I don't know. Yes, Kappa. Thank you. So I don't. I do not know. We'll have to find out with the numbers going up now after that's worked so well compared to all the other things he's had. Line of treatments didn't last very long before they were started to go high, and she had to get him on something else. So what I don't know is if they would up the doses that they have reduced already, or they would go to a new drug with the numbers climbing in his lambda.
I see. So if the numbers are going up again, and then
right,
either way would be acceptable. One is to resume the full dose and dosing schedule, and see whether or not the patient can benefit from that. Sometimes the response is not dose dependent, so it's really hard to tell. And the other way is switch to a different class of medication. So either way, I think it can be considered.
Thank you.
Yeah, in terms of the bone marrow, this is just to confirm disease relapse.
Okay.
Yeah.
Thank you.
You're welcome.
Okay, well, it is 10:06, so we're going to be closing up. I want to thank you, Dr. Yee. We really appreciate your time and your effort and explaining things so thoroughly. So thank you.
You're very welcome.
Oh, I'd also like to mention that Wine and Dine in the D is coming up. It's September 29th. So for those of you, you want to mark your calendars now. So Cure Multiple Myeloma Corporation, Wine and Dine in the D, September 29th. You can go onto our website and purchase tickets, or if you'd like to volunteer or help us in any way, just email me and I'll let you know. So we'd appreciate your involvement. If there's anything, any way you can give, we would appreciate it. Also, Hale mentioned that today the International Myeloma Foundation is having a IMWG conference at 2 p.m. So International Myeloma Foundation IMWG conference today at 2 p.m. if you want to look into that. Is Hale still on?
Yes, he is.
Yes, he is. Okay.
You're on mute, Hal.
Oh, hi, Hale. So
I would encourage you guys to attend those webinars from IMF. So Dr. Brian Dury, he is an excellent myeloma doctor and also educator. Actually, I worked with him to introduce the next generation flow MRD to our institute. So that's why he's very knowledgeable and excellent educator for patients. So if you have time, it will be great to join his seminar.
okay. Wonderful. All right. Well, thank you, everyone. Have a great day. And remember, Dr. Cole is July 5th, and you'll be getting an email from me with a Zoom link for Dr. Cole's Ask the Doctor discussion on July 5th. Thank you, everyone.
Thank you.
Cool.
Thank you,
Thank you, Molly.
everyone.
All right. Have a great
Thank you, Dr. Yee.
Thank you,
Thank
Dr.
you.
Yee.
You're welcome.